This is Module 2, and this is Part 2, and all of this goes for Exam 2, so everything is a 2. And this area is the area of hypertrophy that we want to look at. And if you're thinking in terms of, we've studied the term hypertrophy throughout the curriculum, and this is where, if, for example, if you lift weights, you get larger skeletal muscle, and that's a type of hypertrophy too. But we're thinking in terms of hypertrophy in the heart for this area. And hypertrophy is can be normal, but it can be abnormal. It can be clinical. So we'll be looking at the different types of that. And for this module, Part 2, it's out of the course pack. So we'll be looking at a lot of examples in the course pack, and we'll be starting on page, when we get to the course pack, on page 22 in the large book of the course pack. And so that'll be a good resource for you. The term hypertrophy can also be called enlargement or abnormality or dysfunction. And the term, those are all good terms. The term I like the least is dysfunction, because a lot of times you can have hypertrophy, which is actually a good thing, and it's actually excellent function, especially in an athlete. So, but they are, once in a while you see those different terms for it, but the main term is hypertrophy. And then anything can hypertrophy as far as the chambers, the 4 chambers. We've studied the 4 chambers of the heart in anatomy and physiology, so you can have right atrial hypertrophy, left atrial hypertrophy, right ventricular hypertrophy, or left ventricular hypertrophy. You can have any one of the chambers enlarging or hypertrophying, or even more than one in some cases. And we'll be analyzing the EKG with making a diagnosis of these different hypertrophies. The etiology or origin, what causes this, could be pathophysiological. For example, valvular stenosis. And if you think back to anatomy, you have the aortic valve, which comes out of the left ventricle. Stenosis means a narrowing. If that aortic valve is narrow, then it puts a lot of pressure on the left ventricle, and the left ventricle often hypertrophies because of that. So any valve that's narrow will put pressure on the chamber that has to pump through that valve. So, for example, another example then, if you think back to maybe the tricuspid valve. Tricuspid valve goes from the right atrium to the right ventricle, and if you have tricuspid stenosis, a narrowing of the tricuspid valve, you can have a hypertrophy that would be right atrial because it has to pump through that valve. So think of, if you have a stenotic valve, the chamber that has to pump through it will generally hypertrophy, and that's pathophysiological. If you have hypertension, like high blood pressure throughout the body, then oftentimes it'll be your left ventricle that has to work against that, so that'll hypertrophy. It'll enlarge, and that's, again, pathophysiological. So those are abnormal, and those are clinical. If you have physiological hypertrophy, this is where somebody does a lot of aerobic exercise and weightlifting, and oftentimes the heart gets a little bigger, but this is usually a good thing that will help the person pump more blood during their athletic or competitive activities. And this is something that, if somebody finished athletics or exercise, the heart would go back to its normal size. So this is a physiological hypertrophy. But mainly our concern in this course is working with clinical patients and the pathophysiology of hypertrophy. So if we look to the next slide then, coming off this introduction slide, and go to Roman numeral number 4, I want to talk first about atrial hypertrophies. And you can have 2 of these, either right atrial hypertrophy or left atrial hypertrophy. And let this slide serve as a kind of a little chart on what these hypertrophies are. And we'll be looking at the different criteria for them. So for atrial hypertrophies, first off, you want to analyze P waves in leads 2 and V1. leads 2 in V1. And we'll have a lot of examples of this. And they have a certain shape or morphology. We use the word morphology a lot in EKG, meaning the shape of the wave. And they have a certain look that you can have for the diagnosis. Right atrial hypertrophy, often called RAH, has tall pointed P waves and leads 2 in V1. So if you let's look at an example right now on page 22 in the course pack, you can see that there's an arrow and you have a real tall P wave. And then if you look at the 12 lead, there are also tall P waves and leads 2 in V1. And they're usually often kind of pointed too. That's right atrial hypertrophy. So the right atrium is large. Left atrial hypertrophy has a broad, which is kind of wide, notched P wave and lead 2. And generally an inverted P wave in V1. So if you look at the examples on page 23 in the course pack, you'll look at lead 2 at the top, lead 2 in the middle. Also, you see kind of that notching P wave. And that kind of is a morphology of left atrial hypertrophy. And then if you look at V1 at the top, and then V1 on some of the bottom EKGs on page 23, you see that generally inverted P wave in V1 for, again, left atrial hypertrophy. So looking at, thinking in terms of this material and these examples, you can make a diagnosis of atrial hypertrophies by observing the P wave only, in leads 2 in V1, and looking for these different patterns that have been described. And again, good examples in the course pack. Let's take an example. Look at examples on the PowerPoint. If you go to the next slide, you'll have you have a 12 lead, and all the leads are labeled and everything. And take a chance to maybe pause and look at that yourself. And if you're looking at P waves in lead 2 and V1, those P waves are tall and they're pointed. So this is a very good example of, and we can click forward to the next slide, or I don't have the answer in the next slide, but you can, I'll give you the answer, is right atrial hypertrophy. Right atrial hypertrophy. That's an example of that. If you look at the next slide in the PowerPoint presentation, you again look for P waves in leads 2 and V1, and you can see in lead 2 there's a notched P wave, kind of a camelback or a hump in there. And if you look at V1, the P wave is inverted and more prominent on the inverted side. And so that's a good example of left atrial hypertrophy. Left atrial hypertrophy. So those are the atrial hypertrophies. Again, look for P waves in leads 2 and V1. The other chambers that can hypertrophy are the ventricles. And you can have either one of these. You can actually have both. But generally, you want to be thinking mainly in terms of isolating one at a time, especially for this course as you're first learning this material. The first one that we'll talk about is on the PowerPoint presentation, Roman numeral number 5. And this is left ventricular hypertrophy, often referred to as LVH. And this, we also have examples of this on pages 24 and 25 in the course pack. And left ventricular hypertrophy, the first thing you want to think about is the voltage. And so take the S wave in V1 or V2. Take the larger of the two in V1 and V2. And take the R wave in V5 or V6. Take the larger of the two. And again, if you're looking on page 24, there's a couple of examples. Actually, look at maybe the lower one first where the arrows are. You can add up the S wave distance. In this case, it's on the lower one on page 24 where the arrow is. You have so many millimeters that deflects downward from the baseline. And then you can take the R wave, and in this case V5, where the arrow is larger, and you can add up the millimeters that deflects upward. And if you add up the millimeters of the S wave and the R wave, if you're greater than 35 millimeters, and you can see that in that example, and you can also see that in the top one, and then if you look over on page 25, you have, again, large S waves. I would use V2, and then large R wave, say in V5 or V6. And if you're over 35 millimeters, that is the main criterion for diagnosis of left ventricular hypertrophy, that voltage criterion. That's the main thing you want to look at. Additionally, you can have STT wave changes in leads 1, AVL, V4 through V6, or some of those leads. And so if you look at, for example, best example of this, or a very good example of this, is page 24 at the top, that especially in V5 and V6, there's downward ST segment changes, and it's called a strain pattern. And again, you can look at those examples and see those in various leads, but that strain pattern is very characteristic of LVH. You can also have left axis deviation. And this is something where earlier in the course we said that axis goes toward hypertrophy. So if you have left ventricular hypertrophy, it would be reasonable that you'd have left axis deviation. And the number you want is more than negative 30 degrees, more negative than negative 30, just to clarify. That's on the PowerPoint slide too, where you have something like negative 35, negative 40, negative 45, negative 60 would be axis deviation. So use the skills that you had before to determine axis on EKGs, and then you can decide if there's hypertrophy that way too. And then oftentimes you have QRS widening, which is, we haven't studied bundle branch block yet, but it's usually a wider QRS. It's kind of different than bundle branch block. If you look on page 24, for example, where the arrow is, the two arrows, that's a little bit wider on, say, in V5, a little wider R wave than it should be. Kind of a little wide from left to right. That particular criterion is not real significant. If you have the first couple, you're in pretty good shape for a good diagnosis. But if you have more of these criteria, then you have a stronger diagnosis. A lot of times somebody will say, definite left ventricular hypertrophy, or if they have just a little bit of evidence, they might say suggestive, something like that. But again, the main thing is the voltage criterion. So let's look at, let's do an example together. And again, you want to use the examples on 24 and 25 in the course pack. 25 is just a huge example of hypertrophy where the waves are extremely big. And what they probably should have done is move the calibration mark down to half so it made everything kind of fit the page, but they left it at 10 millimeters, and it's just a big example. But if you look at the next slide for LVH in the PowerPoint presentation, you can see first off that there are pretty tall S waves, or large S waves in V1 and V2. They're about the same, and you could add the amount of millimeters from the baseline to determine how much S wave there is. And then if you look at V5 and V6 for the R wave, clearly the bigger of the two R wave in V5 and V6 is V5. And so you would go from baseline to the top of the R wave and add up the number of millimeters. You can count by large boxes if you want. Every large box is 5 millimeters. And so you take the, say, V1 S wave and V5 R wave, and you add them together, and that's clearly over 35 millimeters. And so you've met the first criterion, and right there you're pretty much thinking there's LVH. If you look at the strain pattern, the next criterion, V4, V5, V6, AVL, a little bit in V1, there's a lot of strain pattern there too. So that gives you another bit of a diagnosis toward LVH, that STT wave change, or downward sloping ST segment. And if you look at the axis, the lead that I would pick to be isoelectric would be lead 2. And again, you kind of have to go back to your axis rules and so forth. to think about this, and probably practice that stuff would be good. The perpendicular lead is AVL. AVL is upright, therefore the axis is going toward -30. So you're kind of right on the border there, but you do have some left axis deviation, and so you have that criterion also. And then if you look at, say, V6, V5, and V6, the QRS complex is a little bit wide, so basically you have everything on the CKG to make your diagnosis of LVH, or left ventricular hypertrophy. This person probably has aortic stenosis, or they probably have severe systemic hypertension as some of the possible situations with this LVH. When you're looking at that EKG that we've been diagnosing, to the far left there's something called a PVC. That's kind of a wide beat. Don't worry about that right now. That's for later in the course. So LVH is very important, and hopefully you're making a good diagnosis of that based on the criteria and based on the course pack and based on that slide in there. Okay, the last one is the other ventricle, and this is right ventricular hypertrophy, often called RVH. And RVH is a situation where you want to look at the R wave in V1. We've looked at this before in the course for various reasons. And just to review again, the R wave should be smaller than the S wave in V1. Should be smaller than the S wave in V1. If you look at page 7 in the small text at the V1 example there, you can see that the R wave is smaller. That's the normal example. If the R wave gets bigger in V1, then you can start to make a diagnosis of different things, like we were talking earlier in the course about posterior wall infarct, and another diagnosis is RVH. And so in this case, that R wave, larger than the S wave in V1, R wave is usually greater than 7 millimeters. And this is generally an example then of RVH, the voltage criteria. And if you have that, then generally that's pretty much a big step toward your diagnosis. You also have potentially STT wave changes in V1 through V3. And this again is called the strain pattern. Probably a good place to look, and we can follow these first two criteria on page 26 in the course pack. Kind of to backtrack a little bit, in the course pack on page 26 you have a tall R wave in V1, and then you have a little bit of a strain pattern also in V1, V2 across there. If you look at page 27, same thing, tall R wave in V1, V2, you got that, and you got that strain pattern going on there too. So STT wave changes in generally V1 through V3. It might, in a lot of cases, just V1 through V2, but that's your another criterion for diagnosis of this. Right axis deviation is the next thing, next criterion. And again, axis goes toward hypertrophy. So with right axis, with hypertrophy of the right side, the right ventricle, you would expect right axis deviation. And usually it's written as greater than 90 degrees, but sometimes they want to call it a little more, like say 110. But generally if you're over 90, you're starting to get over to the right side, right axis deviation. If you you can follow your axis tools for that to determine axis deviation. For example, on page 27, AVR is perfectly isoelectric, and so lead 3 would be upright, and your axis is at positive 120, and that's right axis deviation. And again, sometimes you get the widening of the QRS complex. Again, that's not real important, but again, one more addition to the diagnosis. So that's right ventricular hypertrophy, and you got examples on 26 and 27. If we look at, let's look together at this next slide then. And on this, if you look first at V1 and V2, you have a real tall R wave, and so that is toward your diagnosis. Very large, very good example of that. V1, the R wave is much bigger than the S wave, and so right there you're thinking in terms of potential RVH. there are STT wave changes in V1 and V2, and V3. V4 actually goes on to that. So, that's supportive of RVH. And you might be thinking right now, that tall R wave in V1, how do I know if that's RVH or posterior wall MI? Usually a posterior wall MI does not have that strain pattern, whereas RVH does have the strain pattern, which we have here. So you can kind of look at extended criteria, to make a differential diagnosis. But so far we have a tall R wave in V1 and then a strain pattern in V1 and V2 toward RVH on the example in the PowerPoint. And then if you do the axis, AVR is isoelectric. Probably need to go back to some of the stuff we studied earlier in the course. Lead 3 is upright, therefore the axis is 120, and that's right axis deviation, and so that's supportive also. There's a little bit of a notching or widening of the QRS complex throughout, and so that would be, again, supportive of RVH. So that's a real good example of that, of RVH, and that person probably has the stenosis of the pulmonary valve coming out of the right ventricle, a narrowing of that pulmonary valve, or they might have pulmonary hypertension. Could be the cause of that too. So it's generally not a good situation, but that's RVH. That concludes, again, Module 2, Part 2. And therefore, what I want to do is have a slide here where we take a little bit of a review of that. Okay, Exam 2 comes out of this module, the 2 parts. And this will include 20 multiple choice and true-false questions. These will be worth 2 points each, so a total of 40 points. And this will be, what you mainly want to do is look at the criteria for things and be able to look at the multiple choice questions that way. And then you'll have 60 points worth of critical inquiry type questions. And this will include the reading skills and the recognition. So mainly a lot of EKGs where you're looking at making a diagnosis of different things that we talked about in this section, and making, for example, a diagnosis of whether there's an infarct, and if there is one, what's the location, what's the age, things like that. So a lot of EKG recognition for exam 2. So you have the 40 and the 60 then will give you 100 points possible and 100% possible score on exam 2.